We all know that the NHS and adult social care services are under immense pressure. Demand for care is high and growing all the time, and staff continually have to do more with less. Improving efficiency has become a key target for healthcare providers, and this has benefits, but it also has unintended consequences. For example, the chronic shortage of bed spaces in hospital has resulted in an increased focus on improving patient flow, with discharge as the end game. This creates tension for hospital staff, who want to deliver safe and effective person-centred care, but are often constrained by a system that focuses on getting people out. And for older people in particular, the focus on discharge has problematic consequences that remain largely hidden. We want to show you what the focus on discharge means for the older patient, as well as why and how we need to think differently. The information we present comes from extensive interviews and observations of and with hospital staff and older people and their caregivers. When a person comes into hospital, they hand themselves over to experts. However, this isn't just a handover of their medical selves, but to a certain extent their identity as well. Pyjamas on, lying down, meals provided, waking and sleeping times decided by others, when to have a bath or shower, being given their medications. Things which many people did for themselves before coming into hospital. People become patients, and sometimes bed numbers. Caring but busy staff provide snapshots of information that isn't always understandable. Not wanting to be a nuisance or appear stupid, people can remain passive, seeming disinterested, and sending signals to staff that they don't want to be involved. This isn't to say that staff don't try. During ward rounds, staff ask patients, "Do you have any questions?" But often struggling to know what to ask, most patients say no. This again sends a message of being disinterested, and also implies that people have a good understanding about what is going on, even when they don't. Carers, on the other hand, can be avid information seekers. Their capacity to be involved is often greater because they've not surrendered themselves to the standard processes associated with being in hospital. When patients don't know, carers will often ask and ask and ask, bombarding already busy staff with lots of questions. They dislike pestering staff, but they feel it's their only means of acquiring the information they need to care for their relative after they leave the hospital. A key problem is that a lot of what happens to and for patients doesn't happen at the bedside, and so people don't know about it, particularly work around discharge, much of which happens behind the scenes. And to patients at least, just like that, medically fit for discharge has been decided and the patient is told, "You're going home." This isn't a surprise to staff. They are the process that has decided this. However, the patient has mixed emotions, surprise, relief, anxiety, but outwardly again they often do not question. They don't realise the full implications of handing themselves over on entry to the hospital. They don't realise that very shortly and suddenly the hospital will hand back responsibility for themselves to themselves. And they don't realise that the person leaving the hospital is a new and different version of themselves to the one that came into hospital a few days or weeks ago. The new version is probably someone that is still under the weather, that may be worried about going home and not having healthcare professionals on hand to look after them, who is confused about new medications, and who is deconditioned and slightly less confident at doing their normal activities because they're out of practice. Information at the point of discharge is often limited, and written information is usually second-hand. For example, a copy of the discharge letter is given to patients, but has been written for the healthcare professionals, and so it isn't useful. Consequently, people can leave hospital ill-equipped to handle the challenges of being at home. Couple this with overworked community services that don't have the capacity to receive people back into the community as they once did, and people can return home, glad to be there, but also feeling a bit lost. All of this means that sometimes people return to hospital within a short space of time, and the process starts again. However, without adding a shed load of work onto hospital staff, we can start to think differently about discharge. If we refocus from getting people out of hospital to preparing patients to live at home safely, we can start to make subtle changes to how we interact with patients. For example, if staff have conversations about new medications every time it's dispensed, patients are more likely to remember and understand the changes when they leave hospital and will be better equipped to manage their new medicines when they're at home. We need to recognise that a patient's need to know might be hidden from view, but that being in the know can smooth the journey to taking back responsibility at discharge. We also need to recognise that when a patient hands themselves over, when they enter the hospital system, they are at risk of losing a bit of themselves, and we can try and minimise that by encouraging them to maintain as much independence as possible. With demand for beds high, we don't deny that effective patient flow is important, but helping people to live at home safely is part of improving patient flow. Every person that is able to stay at home is a person who doesn't need a hospital bed. And importantly, by shifting our focus, we can help people to experience a transition to home rather than just a discharge from the hospital.